You're good? You have water, everybody? Coffee or whatever you drink? You have water by your leg?
Yeah.
Okay. Okay, since Eddie is here, we can get started. So, can you all hear me with the mic? I have a little mic attached. We're good, Greg? And the Zoom land is working? I hope so. All right, so thank you everybody for joining on Zoom and also in person. And this is a special type of a grand rounds that we're having today, which is not really a lecture, no slides, not a lot of data, maybe a little bit, but not a lot of data about outcome, research, trials, etc. But it's more of a conversation. And why is this conversation needed so much? Because in the last few years, there's been an explosion of discussion about obesity-related disease, and predominantly the focus, the light that has been shining on these conditions and obesity is related to the explosion of FDA approval for some of the medications, specifically the GLP-1s. So I'll start by introducing the panel, but to tell you that the GLP-1s, as you know, are diabetic medications, or at least initially diabetic medications. And what's really important is that we're learning more and more, and every year there's more and more studies that show that for people with obesity, and it doesn't have to be morbid obesity, people with obesity, and I'm going to focus on one number. There's not going to be a lot of numbers, but BMI of 27. Do you know what BMI of 27 is? I'm about BMI 27. So think about all the patients who you are seeing in medicine and cardiology. How many of them have a BMI of 27 or above? And if you have this BMI and any cardiac condition or risk factor, there are benefits, cardiovascular benefits in using these drugs. So think about if you're medicine, and especially if you're a cardiologist, it doesn't have to be fancy coronary artery cabbage. It could be hypertension or hyperlipidemia or diabetes or atrial fibrillation or subclinical coronary artery disease based on a CAT scan. Whatever it is, plus the BMI of 27, that is enough to be started on a GLP-1 medication that will help you lose weight, but also cardiovascular outcomes. So this is kind of like a little introduction why there's so much attention. And this is the only paper that I have, which is basically introducing our panelists, who all of them generously agreed to join and share their experience with all of you. So first of all, my name is Yair, and I'm a cardiologist, and I have no conflict. I'm the organizer and moderator. I have no conflict of interest related to medications, bariatric surgery, anything related to the obesity world. So I have the pleasure of introducing a few people. So the first is Janine Kyrillos, who is a Diplomate. You all know her. Diplomate of American Board of Obesity Medicine, Clinical Associate Professor of Medicine, Enterprise Medical Director of the Jefferson Comprehensive Weight Management, nationally recognized expert in evidence-based weight management, obesity-related disease prevention, and interdisciplinary care strategies, which is kind of what we're doing here, interdisciplinary care strategies. The next one is Monica Shirodkar. She's a Clinical Associate Professor of Medicine. She is the Program Director of the Endocrinology Fellowship Program. She specializes in diabetes, obesity-related endocrine disorders, the intersection between endocrinology and cardiometabolic disease. The next one, and I'm going by order, not by seniority, is Michael Foster, who's a cardiology fellow. He's the Chief Cardiology Fellow, Senior Fellow, the Louis R. Danone Fellow. He's incoming faculty. He's going to stay here at Jefferson. Cardiology and the Division of Cardiology. It's interesting, and the reason that he's coming here is not because he's intelligent and a well-spoken person, but also he's been doing research since 2018 at Penn and at Jefferson related to obesity, cardiac disease with a focus on heart failure. So, thank you. And then the last but not the least, Alec C. Beekley, who is the chief of the Jefferson Comprehensive Weight Management, also the chief of the bariatric surgery here at Jefferson. And he's a professor of surgery, expert in surgical treatments for obesity, with extensive experience in bariatric surgery, metabolic interventions, and improving long-term patient outcomes. So this is what I have. Thank you, everybody, for joining us. This session is going to be about 45 to an hour, depending on the question that we're going to have. Me and our fellows help us also with maybe seeing if there's questions from the audience later on. But I wanted to start before asking questions to the panelists. And I tried, and we actually had a few meetings in before, we tried to come not prepared. We tried to come really present and listening to each other because we're sure that the discussion and the conversation will be fascinating. But I do want to start with the case presentation. And is Devin here? So we have my medical team, the Red One team, and just this week we had a patient that is very relevant. I modified a little bit of the patient information, but this is relevant. We see this all the time. So there was a patient who is in his 50s, healthy guy, he has a business, he and his wife, super nice guy, and he's obese, BMI of 45, doesn't take any medications. His wife tells him that he snores sometimes, but nothing else. And, never told that he has hypertension or diabetes. He got some labs in the past. So this patient is basically coming in because he's not feeling well, short of breath, and kind of severe fatigue when he's walking in the last few months, but it's getting worse. Again, 50 years old, no medical history, except the morbid obesity of BMI of 45. So he presents, and just to summarize what happened with him, we found that he had a relation with RVR, and he has systolic dysfunction. So our assumption is he's probably been having atrial fibrillation for a few months, or maybe at least a few weeks, and weakening of the heart. So systolic heart failure secondary to the atrial fibrillation. So as part of the management, we take him to the TEE. We try to cardiovert him. Unfortunately, we can't because he has a clot in the left atrial appendage. So we treat him with anticoagulation and slow down his heart rate, treat his heart failure, and send him home to the cardiology clinic. So that's the case presentation. And the reason that I think this is because we as inpatient, but also outpatient, we see this all the time. And we as cardiology community, we think often about coronary artery disease and about systolic heart failure and things of that sort. But again, going back to the first sentence that I opened with, if you have BMI of 27, me, 27 and above, with any cardiac history like this guy, you have to think about the obesity nowadays because there's data. The patients are asking about it. We have different ways to approach this. And I think that we all need to be familiar. And as part of the panel conversation, one of the things that we're going to try to learn is what should a cardiologist do? What should a medicine person do? Should we be prescribing automatically these medications and deciding when to refer to bariatric surgery, which GLP to start, should it be tirzepatide or any other medications, the Wegovy, Ozempic, etc. These are some of the questions we're going to address. And I think I'm going to start with, I'm going to call you all their first names if that's okay. I'm going to start with Alec because we all think about AI and how it's going to disrupt the field of medicine, no matter, especially if you're a radiologist or pathologist. But until now, because of this GLP medications, I don't think there's any field that has been shaking so much and disrupted so much and changed so much as bariatric surgery. And as we discussed, you have seen in the last 2 years only, or even the last year, such dramatic change in the percentage of referrals, but also in terms of the patient population. So maybe you can start by talking a little bit about that, the changes that you have seen in the field.
Yeah, so this, the scary part about the changes that we're seeing is right now we have two medicines. We have semaglutide and tirzepatide, which are FDA approved for weight and as a GLP-1 agonists. And Janine sent me this slide of all of the medicines that are in development in the pharmaceutical industry in the pipeline. It's over 100 medicines. And I just remember thinking we have a tsunami coming and the water is just at our ankles. And just in a year, really a year and a half, we've seen almost across the board, across the country, 30% drop in surgical volume. So if you think about what's happening, this is a very patient-driven field. So patients are out there looking online. They're looking for surgeons. Most of them come in and I find out they've read all about me on Google or what have you. I don't even know the sources they look at. But so this is being driven by patients a lot of times that are saying, look, I can go to a surgeon. I may spend 3 to 6 months to get a workup, at the end of which I have to have this abdominal surgery, which has risks up to including death from a complication, or I can get a prescription for this medicine and start my weight loss journey tomorrow. So there is no small element of that that's driving this sort of change in volume. The other thing that I think we're seeing in the field is now the patients coming to us, there's a lot of patients who had a good experience with surgery in the past, but now may have suffered some weight recurrence or other problems. And so they are confident in surgery being able to help them. So we're seeing a lot more patients coming in seeking revision of a prior weight loss operation. And then finally, I think we're starting to see a lot more patients, and this is what we would hope, at higher BMIs. So we should be reserving the surgery, I think, for those patients with higher BMIs. The other, I think, macroeconomic thing to keep in mind, we have roughly, if you look at population and percentage of patients in the United States that have obesity, we have something like 110 million obese Americans, adults. So that's just over the age of 18.
How many again?
About 110 million. Yeah, somewhere between 77 and 110 million.
40% of the population.
And we operate on about 275,000 a year. And that's actually in general surgery, that's one of the most, bariatric surgery is now one of the most common general surgery operations we do. It surpassed lap chole a few years ago. So the point of that is, well, that's less than 1% of the patients that actually meet criteria for surgery. We're operating on less than 1% a year of the patients that actually need surgery. So that the point of all that is we can't operate our way out of the problem as a population level. And so now having these other medications and trying to reserve surgery for the patients that would really benefit the most, I think is the challenge for us going forward.
Great, thank you. Janine, I think you're also have been so effective to this because you've been dealing with obesity medicine for a few decades now, a couple of decades. And the changes that you have seen, especially in the last few years, are dramatic. And I think that you're thinking overall that it's a good thing because we're shining the light now on obesity and addressing it, either lifestyle, medications, surgeries. What I want to ask you, first of all, is there's a lot of confusion within the community here of cardiology or medicine, because think about it this way. We are like, again, you have the approval of using medications for pretty much most of the cardiology patients. BMI of 27 with anything, even one risk factor, anything at all. What should be Dr. Plana, my boss? He sees an outpatient with this condition. Should he be starting GLP or should he be referring to you or how? What are your advice? What is your advice in terms of multidisciplinary management of these patients?
So very, very loaded question. As surgery has gone down 30%, I don't even know the numbers that we've done. I went from doing this alone to having one nurse practitioner to this year we're up to 18 providers between Pennsylvania and New Jersey providers that are dedicated to treating obesity medicine. And we still have 4 to 6 month waiting list. Actually, it's just finally getting better. So in a perfect world, for this patient with a BMI of 45 and not paying attention to his health for quite a while, in a perfect world, if we had unlimited access, he could come see us tomorrow. I would say, we should have like a comprehensive center where this patient should get started on medical management, be treated optimally, get his medical issues in order, get treated for sleep apnea, he probably has, get his heart optimized, lose some weight, and then have surgery. Several problems. One is access to seeing the providers. The problem with cardiologists prescribing these meds or specialists prescribing these meds, they're very complicated to prescribe. They're complicated dosing. There's 5 and 6 doses for each medication. You have to titrate up properly. If you miss a week, you can get bad side effects when you're restarting. The insurance barriers are phenomenal. The prior authorizations, take a full-time, job, one-to-one for physician for prior auth person. It's very difficult to get them, very difficult to sustain them, very expensive. So that becomes an issue. But perfect world, I would say they would come, see weight management, be evaluated, start the medical journey as they're preparing for surgery. And if they lose significant weight, then maybe they don't need surgery. But in the end, part of the problem with these medications is, can you sustain them long term? Can you take them for life? Is your insurance going to drop? And are we making people well enough? So this guy, let's say he loses, weight and his BMI goes down to 35 or 34, but he still has some metabolic issues. Now he can't get surgery. So we've got him down to stay sick, but not actually get him all the way. So those are my arguments for, incorporating more surgical intervention. They need both. Patients need both. Now, somebody with a BMI of 27, their, lifestyle, there's a lot of problems. I mean, we're not going to, I promised I wouldn't get into the dietary approach, but there are a lot of problems with our dietary recommendations and how people are looking at metabolic health. But looking at metabolic health, understanding lifestyle, exercise. But I do think patients with, I have lots of patients with a BMI of 27 and comorbidities do amazingly well. They do better than the guy with 45 because they've now prevented, diabetes and heart disease.
You mean they do better with the with starting the GLPs?
They do. They don't lose, they don't even lose as much percentage of it. Like the other guy might lose 20, 30%. My guy with 27 might lose 10%, but you see much different changes in their lifestyle and their outlook and metabolically because they didn't get to the point where they're, learned helplessness and also, worsening disease. So by the time somebody, looking at the risk, by the time somebody gets to a BMI of 40 and above, they're the ones that are going to benefit more from surgery. They're not going to benefit as much from GLPs as somebody with a lower weight. They'll still benefit. I wouldn't, but.
Interesting.
Fine.
Yes, Alec.
Just to piggyback on what Janine is saying, I think the model that's been spoken about in the field now is cancer therapy. So you get neoadjuvant treatment, medical treatment, then you get surgical treatment, and then you might get adjuvant chemotherapy. And similarly, we think of this now, we now have another tool in our toolbox. And so, they can get started on a GLP-1, they can lose a little weight, they may become more fit for surgery, and then we can do the surgery. And then now we're seeing patients that after surgery, we put them back on the GLP-1. And instead of a sleeve gastrectomy patient who with the surgery loses 55 to 60%, I now have patients that get sleeve and are losing and get back on a GLP-1 and are losing 75 or 80% of their weight. So there may be a synergistic effect related to surgery and medicine. And we shouldn't be thinking either or, we should be thinking maybe both for a lot of these patients. The other important thing to know, so the criteria that we have historically used for weight loss surgery is a BMI 40 or greater, or a BMI of 30 to 40 with if you had a weight-related health condition. Those were new in 1991 NIH consensus panel, and that NIH consensus panel was dissolved long ago. So the ASMBS and IFSO put out a consensus statement in 2022 that basically lowered those numbers. So BMI of 35 now would qualify at BMI of 30 and above with type 2 diabetes or other weight-related health conditions. And then for patients of Asian heritage, actually BMI 27.5 and weight-related health conditions. So, and some, but not all of the local insurance carriers have adopted those. And so we are now able to offer surgery at patients with lower BMI. So just be aware of that.
Even I didn't know this, but you can, for certain patients, you can offer surgery even for a BMI of 27 and above.
For 27.5 in patients of Asian heritage, they've actually shown that they are getting weight-related health conditions at lower BMIs. And so the NIH consensus statement came out and said, these patients should qualify for surgery. The last thing is they've actually come out, they had a number of statements, and it was November 2022 in the SWORD journal is this new consensus statement. They talked about how obesity is a chronic disease and that insurance companies should pay for revision surgery. Not all insurance companies do that. Actually, Blue Cross Blue Shield only says one per lifetime. And I always tell patients that's like saying you can only get one surgery for your cancer per lifetime. That's because this is the kind of disease that obesity is. But we have insurance companies that we're fighting with where patients come in and they get a sleeve and then they have weight recurrence, and we can't even offer them another surgery for weight.
I think it's the whole concept that you mentioned, that it's like the neoadjuvant therapy, because sometimes patients are really sick, BMI of 50 with a lot of comorbidities, and you want to get them a little bit better for the surgery. So you use, lifestyle modification and the GLP-1 agonist as kind of a bridge until their risk is lower for a type of surgery. I think my next question is to Monica, as a diabetes specialist who's been using these drugs, obesity. You have a lot of, but you have a lot of experience with the GLP-1 medications. Let's say that I see a patient like the BMI of 45, and I decide I'm going to start this medication even on the lowest dose of just to start the process. What is the most important information? Give us like a few tips about potential side effects, the major stuff that are happening if you prescribe the GLPs, and also maybe red flags. Because, for example, as an endocrinologist, a few years ago, maybe 10 years ago or less, we as cardiologists started using SGLT2 for everybody. SGLT2, you put it in the water. Diastolic, systolic, whatever it is. It's the only diastolic medication that is approved, except Panarin from a few days ago. But the GLP medications are like, they're now used so frequently. So what do we need to know about them? And what are the red flags? Like, for example, SGLT2, a red flag is be aware of the euglycemic DKA, which is, sometimes it's hard to detect, but you need to be aware of it. So what do we need to know as people who are managing patients, even if we're not prescribing it directly, but we will be using more and more people with Wegovy, Mounjaro, all of this pipeline that you just mentioned, hundreds of new medications.
Yeah, I think that's a great question. So I always start out by telling my patients, you have to discuss all the options. If you've already decided it's a GLP-1, you want to make sure there's some foundation, right? We can't forget about lifestyle modification. It's not just a quick fix, because if you don't go through a lot of the basic foundation, people stop these medications and they don't want to go back on them. So to truly get the benefit, you want to make sure the patients are educated about the benefits of the medication, but also the major side effects. So typically, GI side effects are very common, and they can be mild. You can have just nausea, worsening of reflux, some bloating, constipation, diarrhea, all those things. And they're all mild, and typically they get better as the patient adapts to the medication, even at the lowest dose. So we tell patients, give it time, it'll get better. And hopefully that's not a reason you discontinue the medications. But at the same time, if they have any severe abdominal pain, and so whether it's a pancreatitis or acute coli, those are things that, they cannot avoid. These are not normal symptoms. I don't typically prescribe medications to mask any sort of nausea. Like some people sometimes give Zofran to get them over the hump. I don't like that because I want to know if you're not tolerating it, to document it and things like that. So those are sort of the extremes with the GI. Anybody with abdominal pain, anybody with vomiting, I actually recommend they go to the ER just to make sure. I had a patient recently who went on a GLP-1 off-label use, not prescribed by me. It was like her partner's GLP-1. She tried it, ended up in the hospital, severe vomiting, dehydration, because it was undiagnosed gastroparesis. So these are just, small cases, but things to think about. So GI is typically the most common one that we tell people about, and also probably the most common reason people stop these medications. So I think it's important to let them know. Try to just get through those first few weeks, and if you can tolerate it, then we can talk about going up on the dose. Some people do really well, and then when you get to the higher doses, they have a lot more side effects. So I tell people about that as well. Some patients, they get this great weight loss up front, and they just want to go up on the next dose, especially with Zepbound, because there are so many doses. And they'll call like every 4 weeks on the dot, can I go up on my dose? Can I go up on my dose? And it's really a conversation of what are your side effects? Are you tolerating it? Because I don't want to put you on, 10, 15, all of a sudden you're at the max dose. You're not going to get that same type of weight loss you did early on. And now you're vomiting, and now you're stopping it, and now you've completely gone off the medication. So we're back to square one. So those are kind of the main things. And then there's all these other side effects. The eye issues we've talked about recently, whether or not there's a strong association, we don't know, but it is something that patients do read about. Everybody has access to the internet now.
What is the eye? Because we're hearing about it. We see it in the news that it could potentially cause serious damage. Is it what do we know about it?
Well, there's some change that happens just with the lens and fluctuations in glucose for the diabetic patient. So that is typically temporary, gets better with time. Most of those patients are hopefully seeing an ophthalmologist. There have been some newer reports of some ischemic type of optic, I think, neuropathy. And their case reports, we don't really understand why that might be. Could it just be the vasculature? Could it be changes in oxygenation? Is it GLP receptors are everywhere? So I think more study and more data is needed on that. It's not something common that we see patients calling about, but it is, we don't have enough information. So if they call me and they tell me they're having a side effect I have not heard of, but it's related to them starting this medication, then obviously we recommend we'll stop it and let's see what happens. And we can revisit if we have to start at a lower dose or try a different type. But Zepbound is very well tolerated. I think the semaglutide is probably a little bit more GI side effects. So some patients who don't tolerate that, we can switch them over to a different GLP-1. But all of that needs to be documented to get it covered and approved, things like that.
Maybe just because it's a little bit confusing, because there's all these names that are floated, and so Ozempic and Mounjaro are different. So Ozempic is basically, maybe you can talk a little bit about it because it got me a while to understand. Ozempic and Wegovy are the same. Mounjaro and Zepbound are the same, except it's a different brand name because the first is a diabetic medication. This is a medication for obesity, but they're almost the same. Like, for example, max up to 2, and the Wegovy a little bit higher, 2.4, but it's the same thing, just a little bit of a different dosing and different names.
Both semaglutide.
Yes.
Yeah. And
So maybe
patients will sometimes want to say, well, my friend's on Mounjaro. I'm like, but you're on Zepbound. It's the same thing.
It's the same.
Simple, just education, yeah.
Are we seeing, we've been using semaglutide since 2012, I think, right? And tirzepatide or Zepbound only since 2022. Are we seeing these eye-related effects more with is it a dose-related effect, or are we seeing it more with one versus the other, or is it just, are you seeing it in both?
Yeah, I can't really say that it's a dose-related effect. I sometimes see it more when somebody just starts the medication. I just had somebody start Mounjaro for their diabetes, and he called me with some eye-related issues. But these patients, once again, the diabetics are seeing ophthalmology, hopefully, for their retinopathy and screening. So maybe they're picking it up a little bit more. But most of it's transient, and it's very rare. It's not a very common side effect. I put it very low down on the list of patients that we have on the GLP-1s who actually have eye issues.
So I want to ask a question for to Michael, but before that, a follow-up question to the two of you, to Janine and Monica. Because when we think about it, like when I have patients who are in the hospital, whatever, AFib, BMI of this, 40 or 45, we often, like in our head as a physician, it's like, okay, bariatric surgery, GLP-1 agonist. But we don't talk frequently about basically lifestyle changes. And again, Janine and I think very strongly about diet as like the right diet. And for many people is reduction in carbohydrates, but we're not going to get that 5-hour conversation about that. So we're not going to talk, but it's not that, like, if you have a patient who's 40 and I go speak with them and it's not that they want to be morbidly obese. They don't want to be. They've tried. They've done this. Most of the people tried something. Oh, we're trying to reduce this. So, it's not a new concept for people with morbid obesity. So when you're talking about before we do the GLPs or surgery, let's start with lifestyle management. Is this an effective thing if we do it like just without medication, without surgery? Just tell them you go to the gym 3 times a week or whatever.
This is tough. I mean, if you're saying I've tried this, I've tried that already, they've already tried lifestyle. I mean, granted, it might not be the optimal lifestyle, but I come to this with the belief that people are doing the best they can with the tools they have, and the possibility of somebody losing weight without some kind of tool or intervention on their own, if they have obesity, is 1 or 2%. I mean, it's very, very, very difficult. And so it's like coming with cancer and saying, well, why don't you try lifestyle first? Like, it's very difficult. Now, does everybody need to be on medication? No, and you can have a high BMI and be actually very healthy. So one of the big things I look at is that weight is only one data point. It is not the whole story. So, patients come in and they've lost, 50 pounds, but their BMI is 26. Oh, my PCP told me that my BMI is still high. And they're out running and they've lost weight and they're doing great. People don't have to have a completely normal BMI. But when you start getting into the cardiovascular risk factors, the sleep apnea, the other things, then you might need some intervention.
But I think lifestyle is very key in terms of, these patients, if they're not able to stay on these medications, and we now have studies that show you stop these medications, your weight comes right back up, right? So if you lose about 20%, but after, 4 months, I think there's a recent study that showed that and it comes back up to almost 14%. So in the patients that went off them, off Zepbound. So you have to have lifestyle as part of, the foundation. If you're not able to have the medication covered, if you go off of it for side effects, if your insurance changes.
And not even that, even on the medication, there's a big, I mean, sure you see it. There's a big difference between somebody that eats the same, but just less. Oh, it's great. I can't eat as much, so I'm eating the same stuff, but less. They don't do as well as patients that purposely, make sure they get the nutrients, the protein they need, start exercising. So even with the medication and surgery, they're not going to have the optimal response. Did you want to?
One thing I'll just say anecdotally, and then hold that question because I want to ask something. We're going to get to the questions in a few minutes, but just anecdotally, I've seen patients who basically they look at the GLPs anecdotally, GLPs as basically a motivator or a bridge to being healthy. Oh, these last 2 years, since COVID, since whatever, I've been like this. I didn't run enough. So, but it's time to start getting a handle on things, and I'll start use the medications just for a few months or so until I get back. And from, again, anecdotally, I don't know if there's research about it, but it doesn't work because once you stop it, it usually, your hunger comes back. I don't know if it's a rebound effect or what, but people, climb back to how they were before. So I want to ask, so Michael Foster is our chief cardiology fellow, as I mentioned, and that's only one of the, and he's going to be faculty here, but also he is fascinated by cardiometabolic and specifically obesity conditions, and he's been doing research on it. So first of all, maybe you can tell us just a little bit about the research that you're doing, and also tell us what are your thoughts about, weight reduction. I know that you're very interested in bariatric surgery or medications, but an ability to reduce dramatically the weight from BMI of 35 to 25. How does it affect the heart?
Yeah, so bringing it back to the patient and the fact that this is a cardiology grand rounds, I thought, why are we talking about weight? The reason why I started doing research in this field was really to bridge the gap between cardiology, specifically heart failure, and the metabolic bariatric surgery group. So the reason I was brought on was because there was this, about 10 years ago, this propagated theory of the obesity paradox in heart failure, where it was observed that patients who had either overweight or low-level obesity would survive longer from the time of diagnosis of heart failure until end of life. So they lived longer, theoretically, if they had extra fat. So we called it into question. How could this be a positive thing? What we found is a few things. There's a lead time bias. Patients are presenting with shortness of breath earlier to the ED, so they're getting BNP levels drawn in X-rays and everything done earlier, and they're diagnosed with heart failure sooner. And so they live longer because they were diagnosed earlier. But you're also selecting for patients that don't have cardiac cachexia and sarcopenia as much. They're able to have that metabolic advantage where they can gain fat and weight, and it means that they're less sick. So there's a lot of reasons why that could be, but what we found in it and through a lot of mostly imaging studies that were done over the last 7 or 8 years is why fat is bad, specifically for just overall inflammation, endothelial dysfunction, AFib, and specifically HFpEF. So the easiest way to bring it back to that patient is to say the typical patient who presents with a BMI, let's say 40 plus, who all of a sudden feels short of breath, they're hypoxic, they're in AFib with RVR, and before this they were fine. Like what tipped them over the edge? So there's so many, it's so multifactorial, but the easiest way of explaining it, and I've been footballing in my head how I'm gonna explain this, is you have both intramyocardial and you have epicardial adipose tissue. It serves an endocrine, a paracrine function, as well as just physically deteriorating the heart itself. So with the intramyocardial effects in the left ventricle specifically, you have disruption of calcium signaling. You have lipid accumulation within the myocyte itself, which then with insulin resistance is gonna make you undergo lipolysis. Free fatty acids gather in the mitochondria and then cause mitochondrial dysfunction. You also then have the less efficient way of contracting the heart, which is beta oxidation of lipids, whereas glycolysis and ketogenesis would be quick burning fuels. Beta oxidation takes some time and it's less efficient. So between all of those, the LV, and they've shown this, that patients with HFpEF have higher myocardial fat stores, both in the epicardial fat layer and within the myocardium themselves. They get diastolic dysfunction. They have increased E over E prime levels, so diastolic dysfunction, and increased left atrial volume index. So then fluid backs up. Now these patients are already volume overloaded state because with increased body surface area, you're going to have increased volume. So then blood backs up in the left atrium. Left atrium is supposed to relax during, and I just took the echo board, so apologize if I get a little too in the weeds, but during what we call reservoir portion of the atrial cycle. So when the right ventricle squeezes, the atrium is supposed to expand and accommodate for all that blood that's coming over. The problem with it is with all the epicardial fat that's surrounding left atrium, you have myocardial disruption, fibrosis, and apoptosis of those cells, which then disallows the atrium to expand. And we see this decreased reservoir strain in patients with severe obesity. It then relies too much on the contractile force of the atrium. So now it has to squeeze harder to push out what little blood it has left in it. Remember, it's a whole circuit between the left atrium through the pulmonary vasculature. So with all of that extra pressure in the atrium, it's also in the lungs. So pulmonary hypertension comes along with this phenotype. With the disruption in the myocardium, you also get electrical disruption. So with the dilation of the pulmonary ostium, all four of them, hopefully, then you get increased risk of AFib. You get increased risk of AFib just from the disruption of the electrical signal in the posterior left atrium. And then because you're so reliant on this contractile force of the atrium, they're already at risk of AFib. We haven't even talked about OSA. They go into AFib, they lose the contractile force, and now that's this downward spiral of pulmonary edema. And so they need that atrial kick. So it's HFpEF, it's inflammation, it's endothelial dysfunction, myocardial dysfunction, it's everything. There's so many things. And we can treat the OSA, we can ablate the AFib, we can put them on amio and cause other problems. We can give them diuretics to have them, have less fluid and cause them to go into, have renal issues and be dehydrated. But in reality, the crux of the matter, the reason why all of this is happening is because of adiposity. It's all about weight. And that phenotype of person I described happens, there's probably somebody sitting in the ED right now with it. So it's super common. And the only proven durable method of weight loss is bariatric surgery and in conjunction with GLP-1s, like you mentioned. So more research is needed to look at the effects of obesity on the heart specifically, and something randomized and not retrospective finally that's going to show an improvement. So that's where my research goes.
This was mind-blowing. Thank you for.
Was this recorded so I can go watch this more slowly?
Yeah, it's recorded in two ways. It's recorded.
I was wondering how to explain it because I thought it was going to be a lot of internal medicine, like interns and med students. I'm like, okay, I had to make it simple. Now I'm looking at the audience. I'm like, oh, they understand.
A lot of people are going to watch
This
it.
is great.
Yeah, that's true.
I just wanted to say that this is fascinating because the vast majority of the cardiologists and medicine people, including myself until recently, like when we see these people who are coming with morbid obesity and atrial fibrillation and diastolic, oh yeah, this is all sleep apnea. Like the mechanism of sleep apnea, adrenergic, all of this. But I mean, with researchers like Michael and others, we're learning that the obesity is working in so many detrimental ways to harm the heart eventually and the whole body. So this was fascinating, Michael. Thank you. And I'm sure that, like, general this conversation, we can go for hours, I'm sure, but you're limited. Asking, maybe you can help us with the question. First question was Eugene, please.
Just great presentation thus far. My question really relates to the need for psychological interventions, social interventions, and how that plays a role in trying to ensure the success for these patients. Because certainly we've had numerous patients that go through bariatric surgery, but then in fact may, despite success with that initial weight loss, actually revert back, start to potentially cheat, quote unquote, and do gain weight back. So what role do those interventions play in successful weight loss and maintenance of weight loss?
a great question. Before you answer, I wanted to add to that question something that we spoke about. So you're basically asking about psychological health, but we know that one of the barriers for bariatric surgery does not exist with GLPs. If its insurance is okay, you start the medication. Bariatric surgery, you need to have multiple. Depends on the insurance, you told me, but depends on the insurance. You have to have multiple meetings, not only with the psychological team, but also 6 appointments or so with nutrition, meaning that for some of the insurance, it's at least a 6-month process. But I think that it's a great question about the psychological. And I will also add, does the GLPs have something to do with the psyche as well? Because some people are saying it's calming down, it makes you less explosive, more, so maybe any of you can comment on this question.
I'm happy to. The GLPs have really opened up our understanding. Sorry.
Go ahead.
We're understanding so much more about the psychological association with eating, and so like this person that had surgery that you talk about has surgery and then they start to cheat. Is it cheating, or is our brain hardwired to want to survive and to want to eat? And as you lose weight, you want to prevent against starvation, and so there are signals in the brain that start to ramp up and make you more hungry, and that's why we need multiple layers to this. Fascinating thing about the GLP-1s is patients that think they had, and surgery too, patients think that they had no willpower, they had no ability to stop, they can't stop thinking about food, they can't stop eating. All of a sudden they take these meds and they're like, I feel like a normal person. Like the food noise that they talk about, like I'm not, driven by food. I can think about other things. And they realize that it wasn't just their willpower, that there was something else that was helping. And I tell patients with surgery too, surgery is not just making the stomach smaller, it's intercepting some of those hormones that affect hunger and satiety. So there are, definitely people that need to look at, psychologically and look at behavioral intervention and habit formation, and definitely need to work with them more closely. But there are a lot of people that do really well and change habits and change their outlook just by giving them tools that actually work, and not giving them this sort of learned helplessness, like, eat less, move more, it doesn't work, you regain the weight, so then you give up and then you just eat more. So if that makes sense.
Yeah, I think we have to start thinking of obesity as a diagnosis and a disease, and less like a failure of behavior. It's sort of like how we're thinking about addiction. I mean, if they're cheating, then there's a problem with the phenotype. There's a problem with the disease.
So you're basically saying, kind of like what Alec was saying, is that we really need to start framing the whole obesity, morbid obesity, as a chronic disease.
Not only is it a chronic disease, but one in which our again, social and economic systems and our current food industry have a huge role to play. Like, we can't solve this issue with medicine and surgery alone. We have to, there's a bigger work that has to be done. I think it's Virchow that said medicine is at its bone and marrow of social science. And these patients absolutely need psychiatric support. We send all of our patients for that. We send them all for dietary support. I tell my patients, look, the hardest part of this whole process is you changing habits. Habits by definition, things we do without thinking about it. To change a habit, we have to think about it every day until we can stop thinking about it, because it's the new habit. And that is really a long process. Getting back to exercise, my patients, it's anecdotal. The data suggests that exercise doesn't have a huge role with weight loss, but I tell patients it has a huge role in weight maintenance. And I try to get them to focus on exercise, not for the weight, but for all the other benefits it provides you in terms of reduced blood sugar, reduced blood pressure, reduced stress, better sleep, all the other wellness things that exercise gives. But one of the other anecdote I'll give is, when I was in the Army, I was at Madigan Army Medical Center. The majority of our referrals for weight loss surgery came from Bremerton Naval Hospital, which is on the Olympic Peninsula. And one of the patients I treated up there told me, all of your patients, or a number of patients, we all go to twice a week to this bar in Bremerton and get drunk. And she had a lot of insight. She's like, we just replaced one addiction with another. And if you look at the data on rates of alcoholism and substance abuse after bariatric surgery, they're higher than the average population. We see these patients say, I had some sort of unhealthy relationship with food, whether it was an addiction. And now that you've restricted me from doing that, I'm finding something else. And so what that indicates is that there is an underlying psychiatric or social condition that we may not be addressing if we don't work at it.
Fascinating, Monica.
Just one other point, and I agree. I think the majority of people do very well, and we hear a lot about the reduction in food noise. But as one of the rare side effects in patients that do have underlying mood disorders and whether on medications for depression, anxiety, I do have that conversation that this may worsen your mood as well. There
Really?
are very rare like case reports about suicidal ideation, worsening of depression. So as a cardiologist, if you're going to start somebody on that medication, that's another side effect that I think is important to discuss.
Oh, fascinating. Just to frame the conversation, there's a few other questions, but to be mindful of everybody's time and respect of the panelists, we're going to have a hard stop at 8:15. So we have about 15 more minutes. Sally, I think, who was the first? Sally or how? Yeah, Sally. It's working.
I find that the greatest hindrance for prescribing this as a cardiologist is navigating the insurance. I have two patients who are exactly the same, and one got approved for Trulicity, the other one, they said they can't, and then, I go down the list of like, well, maybe this one will get approved. And then I find after like trying 3-4 times and like everything gets denied, like I just want to give up. And so, I'm like, okay, go to the weight management center and maybe they'll, they're better at navigating the insurance aspect. And then, they'll come back to me and they're like, I can't get in for 9 months. So like, I know these patients need the medication and sometimes I'm their first contact to starting these. But what are your tips and how can we get better access to it? How can our patients get better access to it?
I mean, how much, we only have 15 minutes, so it's crazy. First of all, you have to prescribe the right brand name. So if it's cardiovascular risk reduction, it's Wegovy, not Ozempic or Trulicity. If it's sleep apnea, it's Zepbound, not Mounjaro. If it's diabetes, it's Mounjaro, not Zepbound. So, one thing is that you're getting the right diagnosis, and you can't even go by that anymore because now CVS Caremark is requiring Mounjaro for weight loss, off-label, and Pennsylvania Medicaid is now going to require Ozempic for weight loss instead of. So before I would tell my patients, look, Wegovy for weight loss, Ozempic for diabetes. I don't care if this is covered. You don't have diabetes, I can't order Ozempic. Now you don't even know if you can order off-label, on-label.
Chaos.
It's chaos. And then it might be covered, but then they change insurance and it's not. Sometimes some of them now are requiring the most, stringent, like you can't possibly get it covered. They have, documented with receipts from the gym or Fitbit data showing their heart rate elevated, 3 times a week, and working with a weight management specialist. There's so many tricks. So right now is a really, really difficult landscape to start meds. So I don't, that's not helping you. I will say that we use Jefferson Specialty Pharmacy and they do a lot of the prior auths. And if you get the right person helping you, they kind of know a lot of the ins and outs. So we send our meds to them.
Another option is for them to pay out of pocket. So Lilly Cares does a program where as long as they have a prescription, the patient can pay out of pocket for 1 month supply, and based on the dose, the cost can, start at about $300 a month, which is not cheap, but it goes up. But it's an option that we do talk to our patients about because either they get stuck in the prior auth, insurance changing issues. So
Is there a way to get a list of like, okay, these conditions, these are the brand names to use, and for insurance specific, because
If you want
I don't know,
email
like
me-
without, except for trial and error. And I did use Jefferson Specialty Pharmacy, and they also said that
Then
it's
I'll send
not.
it to the group.
if you want to email me, I can take you through. The out-of-pocket, both Wegovy and Zepbound are available for $4.99 per month. For Zepbound, it's $3.50 for the first dose, and then it's $4.99 for all other doses through the Lilly Direct Pharmacy, self-pay pharmacy with a prescription. Wegovy is $4.99 per month for any dose at any pharmacy. They can use the patient savings card. So that does. And sometimes, this is off-label, but sometimes I'll get them to a higher dose and then have them take it every other week. And so they can stretch that, to $4.99 every 2 months, possibly. So there's some tricks that we do.
I think that just, the next question is Dr. White, but just to mention that this is so chaotic and confusing and difficult, but that's why Janine was pretty much on, like, when we started talking about SGLT2s a few years ago, Janine was herself, and then sometimes she had an NP. Now her team is up to 18, and they can't hire fast enough. It's like you're hiring. She's hiring so much because one of the things that they can do, they know the system. They know how to navigate the system and get the right patient based on the insurance, the age, the whatever, the comorbidities, the right medication that will be approved, and the process is not going to be too long. So
And
remember,
sometimes it's just not approved, no matter what we do. I can't.
at least they give it the best chance, the comprehensive. So remember that you have this option, and I'll tell you, all these panelists are always available. When I call them or email them, they respond to me in minutes, and they're very good with sharing every information and helping you in whatever you need. Dr. White, yeah, Howard.
You for putting this on and for the panelists. These drugs in the right patient are amazing. And there was not a consensus conference, a conference at the National Academy of Medicine a couple of months ago, looking at the use of these drugs for the next area of Parkinson's disease, others, et cetera, et cetera. I've been here before. I'm going to ask a question of the group. You don't have to answer. Where were you September 1st, 1987? 1987, September 1st. College, somewhere you've been born maybe. I was here at Jefferson, 30 years in attending, and on that date, a blockbuster drug was released, the first statin, Locust Statin. And I remember seeing a panel just like this because before the use of statins, one of our key treatments for those that could afford it was surgery. Ileal bypass was the way to lower cholesterol. It was a tough surgery, tough times, and we found it took decades to get statins out to the people that need them. And if you look in primary prevention, up to a few years ago, only 1/3 of the people who need statins are on them. We found that we had to get them out to the primary care doctor, and we had to make them as simple as possible. And I will tell you, when statins first came out, you had to attest that the patient tried lifestyle modification for X months. You had to get CK enzymes and LFTs every month, like for the first year on statins.
Oh, amazing. Okay. They walked in, she's driving back now. She's going to wait.
Oh,
Or starting off.
Can you mute?
Good.
Can somebody mute the? Can somebody mute the Zoom?
Her because she was out without.
Interesting conversation, right?
I am a colleague member of this lady, but she's not checked in yet, so let me come back.
Please,
Yeah.
can
Yeah,
those
no,
on Zoom
yeah.
mute yourself?
Yeah, no, you address, I'm the mom and you're the kid,
So I need to.
yes.
You know.
I don't know. Stop this.
Annette, turn off your mic.
Go ahead, sorry.
All right, so the question for the panel. We found that the more statins were limited to subspecialists, and endocrinologists were the first that prescribed, we would refer to endocrinology. How do we make these a primary care drug, simple to use, and help get it out to the people that need them?
I would love that, and that's part of my mission is to educate primary care and have primary care be comfortable treating obesity just as they treat hyperlipidemia and non-complicated diabetes. I think we do need to make these meds easier to prescribe. Even the dosing is difficult. So the education and understanding the dosing, understanding the disease itself. I get a lot of patients that come from primary care and they were started on the starting dose and never escalated. That's a waste. they're not losing weight, they're not doing well, they're spending the money and they're not being treated. So understanding the dosing and and then also understanding the behavioral and lifestyle interventions that go with it. It is complicated, but that's a great analogy with the statins. I want to learn more about that history of how did we get primary care involved. I think the insurance barriers are a big deal too.
Yeah, I think we're already seeing it. I have a number of patients who say, I got my GLP-1 prescribed by my primary care. They are starting to hopefully gain the sophistication that they need. And hopefully our group and Janine's group can make that information more available. This is going to be driven by patient demand. The other thing I'll say is, we have oral versions of these coming out. It's supposed to be in the next year, FDA approval of an oral GLP-1. And so this idea that I don't want to give myself a shot once a week for the rest of my life, they may not have to. They may be able to take a pill. The last thing I'll say is, we're already getting into the realm where AI is going to be asking the research questions. AI is going to be help design these medicines. And so if anything, the pace of these things coming out is going to accelerate.
And I think we have time for 2 more questions. Amin, are you still here? Maybe you can read the question of Dr. Alvarez. And also, Dr. Plana, you have a question. I'll just mention that what is fascinating that Alec told me is that he believes that the future will include robotic surgeries. And when I'm saying robotic surgeries, it's not a human like Dr. Sloan back then
means the
who was
future of
doing the
AI.
robotic, but the robot itself. You tell it what to do, and it operates. And it's already different models on animals because of the generative AI and all the data. The robot arm that is becoming so sophisticated can actually do this. So maybe we're looking, like you were saying, 2027 or 2030, that robots will actually do surgery, but that's a whole different talk. So Dr. Alvarez from the Zoom lab.
Thank you very much. I'm sorry I'm not there in person. I'm away, but I have a comment and a question. First of all, Dr. Kyrillos, thank you. I am a member of your program, and it's been really life-saving for me, and I appreciate your staff is incredible, and what a great service. And to Alex, thank you for taking care of our sickest of the sick with severe LV dysfunction, morbid obesity, especially those that are on LVADs, and you taking on the challenge of helping those patients with bariatric surgery. So thank you very much for that. And my question is that my wife is a pediatric provider, and she's seeing almost 1/3 of her patients are obese. And I was wondering if you guys can just comment how we're going to tackle the problem in the pediatric population, which is a very difficult one. And a follow-up to that is just perhaps a word of caution on the use of these GLP-1 agonists in patients with severe LV dysfunction with EFs of less than 20%, who in the past, there's been a trend towards harm in that patient population, and how do we address it? So thank you very much.
That would be a question maybe we'll start with the last question, which is Michael can comment.
Yeah, so I think the problem with the studies that were done in the HFrEF population, where if anyone isn't aware, it basically showed that there's an increase in heart rate and arrhythmias, but not an improvement in LV dimension and function in HFrEF patients. The problem is they didn't pick an obese HFrEF population specifically, and it's the reduction in adiposity that we believe would be the most benefit. So it was probably more of a selection bias, but there's more studies that are coming out that are ongoing now that we're waiting for. So I wouldn't come to a conclusion about HFrEF with GLP-1s by yet.
What's that?
Who needs AI when we have the encyclopedia here?
Do you want to comment any of the other part of the question, Dr. Renee? Pediatrics, that's an important point, because we see a lot of pediatrics obesity.
I think it also goes back to, once again, starting that lifestyle early on. Why are these children at a young age becoming obese? So is it their activity? Is it their food? Is it the family? Is it the access to healthy, meals?
Smartphones for kids.
Semaglutide is approved for over age 12. But once again, is this something you want a 12-year-old to be on for lifelong? I can't even imagine that. So I think we have to get back to the basics.
Yeah, and the basics is a societal issue. Because to say, oh, the kid's not moving enough, well, maybe because, they don't have the energy to move because of the food supply and the school lunches are, harmful. The dietary recommendations and there's so many things that contribute to obesity. There's the endocrine disruptors and additives and, things that we just don't even understand. I tell my patients, they're like, do I have to take this forever? I'm like, well, if we could beam you to a desert island or to 100 years ago, maybe you wouldn't have to take it. But when you live in this society, it's really hard. And so it comes down to a societal issue, and we're not going to fix that overnight. So how do we treat these patients in the meantime?
You want to come?
No, I was just saying, I think I agree exactly with what Janine said. This is a case for organized advocacy from medical, groups, because this is not going to be fixed at our level. The fact that if the cost of these medicines that we've been talking about in the United States, patients say, oh, they're telling me it's a $750 to $1,000 a month. And in Europe, they're $65 to $85 a month. So why is that? Those are the issues in our system that are not going to be fixed by us, but are going to be fixed by advocacy and constant sort of pushing in an organized fashion. Very challenging, big challenges, as we know.
And we'll take one more question by the new chair of cardiology, Juan Carlos Plana. Oh, hold on, we'll give you
So the question that I have is, to the best of my knowledge, the mechanism by which the GLP-1 agonists work is mainly by decreasing the appetite of the patient. So the question that I have is, how do you prevent loss of muscle mass when you put these patients in the GLP-1s? Because they are just eating less.
I'm surprised this didn't come up sooner, and I actually wanted to interject this earlier, especially with lifestyle intervention. Any type of weight loss is going to result in muscle loss. I mean, you're seeing it with bariatric surgery patients. It is so important that patients do resistance exercise. I mean, we drill that in from the beginning. Protein and resistance exercise has to be part of this. When you lose weight quickly, Monica, if you have.
Yeah, no, I agree. I think it's, protein, resistance exercise. Really making sure, remember, these people came to where they are at this point because they didn't have the best eating habits. And so that also has changed, and they have to really understand that even with the weight loss, that there's important nutrients that are missing. And they might not be eating as much, but then they still have to eat the right types of foods.
It's also sort of counterintuitive. If you're losing weight, why would you have to exercise? Because you're losing the weight. That was the point. But you're not exercising for weight loss. And so it's kind of, it's another bit of the whole reason why you need a whole center to explain the entire process of this. It's not just prescribing the medicine.
And the other thing, I mean, Alex said it earlier too, patients that, exercise doesn't have great data in terms of weight loss, but for weight maintenance. And so you see patients that they lose fat and muscle, and then they regain the fat and they end up metabolically in worse shape. So getting that, and I also have patients that stop or slow down the GLP-1s, and if they're exercising, they do better and are able to maintain weight. If they're doing some exercise and some resistance type activity.
So I think there's more questions both from Zoom land here, but we're out of time. If you want, you can come to the front pretty soon. I wanted to thank our amazing panelists from Janine, Monica, Michael, and Alec. And this has been fascinating, and we may arrange more of these because we're scratching the surface. This is so timely and interesting. And just remember that we have the option. These amazing individuals are always so receptive. Email, phone calls. You can ask me and I can connect you to whoever you want. We have a comprehensive weight management center, the bariatric surgery. Keep it in mind. In the same way that when you have people who smoke, you think about the smoking, think about those people with a BMI of 27 who have comorbidities, that we have a newish tool that we can manage. So again, thank you very much. This was fascinating.
Thanks to you, Yair. This was a very great experience.
Thanks, Yair.